Hi, I'm Ruben Strayer. I'm an emergency physician and addiction physician living and working in Brooklyn at Maimonides Medical Center. Alcohol is the most used substance in the world, and because emergency clinicians manage the harms associated with unhealthy alcohol use on every shift, and because so many people with alcohol use disorder use the emergency department as their primary contact with the healthcare system, we are uniquely positioned to intervene. Here we are going to discuss identification of unhealthy alcohol use and alcohol use disorder, and management of one of the most important complications of chronic alcohol use, alcohol withdrawal syndrome. Because so many emergency department visits are a direct consequence of unhealthy alcohol use, we can go a long way to improving the care of people with alcohol use disorder just by engaging the patients who are manifestly affected by it. Simply incorporating a recognition of the disease and offering to help as part of your routine emergency assessment is a huge step forward. I will often say something like this. We see a lot of people affected by alcohol use disorder and unhealthy alcohol use, and there are effective treatments that we can start here in the emergency room. Are you interested in reducing your drinking? Many patients will say no, but some will say yes, and you can make a huge impact by taking advantage of the occasion of the teachable moment of an emergency department visit to initiate AUD treatment. For patients who are not evidently affected by alcohol use disorder, you can screen for the disease using validated screening tools like the single item screener. The single item screener asks, how many times in the past year have you had 5 or more drinks in a day for men, or 4 or more for women? And if the patient says 1 or more days, that's a positive screen. Each positive screen should follow up with further evaluation for need for alcohol withdrawal treatment and AUD treatment. Alcohol withdrawal syndrome results from an imbalance between inhibitory and excitatory neurotransmission in the brain after chronic alcohol use is abruptly stopped or significantly reduced. This causes a decrease in GABA-mediated inhibition and an increase in glutamate-mediated excitation, leading to a state of CNS hyperexcitability that manifests as typical withdrawal symptoms such as anxiety, nausea, tremors, agitation, seizures, and in severe cases, delirium tremens. The best way to determine if your patient is at risk of alcohol withdrawal is to ask them, have you ever gotten the shakes when you stopped drinking? In general, patients known to drink recently, regularly, and heavily are at risk. For patients who are in alcohol withdrawal or at risk for alcohol withdrawal, perhaps the biggest emergency department challenge is to determine who can be managed with oral medications as an outpatient and who requires closer monitoring and or hospital admission. Most of us probably overtreat with IV meds and consign patients to admissions they otherwise wouldn't need. This box summarizes features that indicate those who likely need to be hospitalized or managed in a subacute withdrawal management setting like a detox facility. The treatment of severe withdrawal involves careful and close treatment with benzodiazepines or phenobarbital. If benzodiazepines are used, diazepam and lorazepam are both safe and effective, with diazepam having the advantage of a faster time to peak effect, which allows for easier titration, as well as active metabolites that smooth downstream management. Lorazepam can alternatively be used in severe decompensated liver disease. The most important aspect of initial treatment of severe alcohol withdrawal is frequent reassessments to determine the need for repeat doses, which should be administered every 5 to 20 minutes in escalating doses until the patient's condition has stabilized. This is called front-loading benzodiazepines and can prevent patients from needing a higher level of medical care. Phenobarbital, given intravenously or intramuscularly, also has a place in the treatment of severe alcohol withdrawal. It can be used as an alternative to benzodiazepines, which is important with recent drug shortages. It is usually given in loading doses ranging from 6 to 15 milligrams per kilogram depending on the patient, or in lower doses like 130 or 260 milligrams as an adjunct in benzodiazepine refractory patients. Have a low threshold to replace thiamine via intramuscular or intravenous route and electrolytes in this group, as well as evaluate for common complications of severe alcohol use disorder like traumatic injuries, acid-base disturbances, and liver disease. Alternatively, patients with ample support and safe housing with mild or moderate alcohol withdrawal can be treated in the emergency department with oral medications and then as an outpatient with an emergency department-based prescription. The 3 medications most commonly used for ambulatory management of alcohol withdrawal are diazepam, chlordiazepoxide, and gabapentin. Patients who present to emergency departments with moderate withdrawal that might progress to severe, who are not clearly suitable for outpatient management, should generally be treated with higher doses of diazepam or chlordiazepoxide and observed to make sure they improve. We recommend this protocol for outpatient management of alcohol withdrawal, which offers several options based on the patient's projected withdrawal severity and preferences, and is centered on a 4-day taper. The risk of causing harm with an appropriate regimen, even if the patient continues to drink alcohol, is very small. So unless your patient says, "I'm not interested in reducing my alcohol use, I'm going to return to drinking right away," prescribe. Alcohol withdrawal is a process that generally takes 3 to 5 days and can be unpredictable. So the most important element of an outpatient treatment plan is that the patient can regularly be checked on, which can be clinic visits or telehealth assessments, or a friend or family member who is able to call or stop by every day to make sure everything is well. As always, if the patient is getting worse on recheck, they should return to medical attention to be evaluated for inpatient management or other therapies. Emergency clinicians can have a huge impact on patients with the very prevalent, very dangerous, but very treatable disease of alcohol use disorder by identifying affected patients and treating the withdrawal syndrome and underlying cravings that perpetuate unhealthy alcohol use. Incorporate these strategies into your assessments and management plans to give your patients their best shot at recovery, and offer medications such as naltrexone, camprosate, and disulfiram if they are interested.